Acid base balance exam questions. Here is the first question. A 30-year-old woman was admitted to the trauma unit following a motor vehicle accident. On examination, she had multiple fractures and a cold, sun-nosed periphery. Her pulse was 140, barely palpable, and her blood pressure was unrecordable. So just from the way it's announced, we can see this person has got some excess carbon dioxide in the body. The following laboratory findings were obtained. Sodium is normal, potassium is high, chloride 90, that is low, bicarbonate is low, glucose, which is 6, is high, urea 8, that's high, creatinine is normal. Creatinine is telling us about the kidney cause is going to be excreted there. So meaning the kidney function is fine. Arterial blood gas, pH is 7.1, that's low. Partial pressure of carbon dioxide is 4.4. We can see it is a bit low. SBC is 10, that is also low. So what we need to look at is this. Comment on and interpret all the biochemical data. What can be the interpretation here? Looking at the pH, a partial pressure of carbon dioxide, and SBC. What is the problem? Anyone that can help? Let's start with the pH. Is this acidosis or alkalosis? So this is acidosis. So the next thing for us to be able to comment, remember acidosis, it's either we have gained acid or we have lost base. If we have lost base, it means that bicarbonate should be low. If we have gained acid, it means carbon dioxide should be high. But look at this, carbon dioxide is not high. So meaning that this can't be gaining of acid. Instead, it is the loss of base, right? Because of this. And if it is a loss of base, definitely it can't be respiratory, right? So this is metabolic acidosis. But look at, because it is acidosis, the pH is low. What the body is going to be trying to do is to do some compensation. How is it going to be doing compensation? By the respiratory system. By the respiratory system, you are trying to not remove much of the carbon dioxide. You are trying to maintain the carbon dioxide, okay, in the body. If you look at here, the partial pressure of carbon dioxide is nearly normal, but it's a bit low. It's a bit low. So there is just only partial compensation. So metabolic acidosis. Every time something is acidosis, we are supposed to be, actually, please let me explain this again. This is acidosis, and since it's acidosis, we want to compensate for that. How do we compensate acidosis? By trying to increase the pH. How do you try to increase the pH when you're talking about acid? By reducing the acid. So you can see carbon dioxide is a bit low. We are trying to reduce carbon dioxide because carbon dioxide is actually acid. So there's just a partial respiratory compensation. That's why the carbon dioxide is just a little low. How that's okay? Is that okay? Okay. And then another thing that we can see is, because the question is saying using correct biochemical terms, comment on the interpretation of all the biochemical data. Potassium is high there. So you can see there's also hyperkalemia. The chloride is low, hypochloremia there. But what is important to comment on acid base balance, especially the potassium, which is hyperkalemia. And then we have got hypochloremia, and then when you look at glucose, glucose is high. What is the name of the condition? There is some form of hyperglycemia. Urea is high, that is increased urea, and then creatinine is normal. So that is the interpretation of all the biochemical data. Explain the likely cause of this acid base disturbance. So we have said this is a metabolic acidosis with just a partial composition. What could cause this? Anyone that wants to help? Yes, please. Yes. So if it was respiratory acidosis, carbon dioxide would have been high. So the first thing to interpret, first we look at the pH. The pH is low, that's acidosis. So now we determine whether it is respiratory or or metabolic. If it was respiratory, carbon dioxide would have been high. If it is metabolic, bicarbonate is supposed to be low. So since bicarbonate is low, that is respiratory, I mean metabolic. But why is the bicarbonate low? That is a composition, the respiratory composition. Hope that's okay. Yes. So any possible cause of metabolic acidosis? Anyone? Remember, there are a lot of things that can cause re- metabolic acidosis. One thing can be lactic acidosis. You have got diabetic ketoacidosis, so they've not given us information about the diabetes and such. But we can talk of the lactate. Look at urea. Urea is a bit high, so that can as well help us. There's pre-renal urea, so meaning that there's poor perfusion to the kidney because of the urea that is high. There's poor perfusion to the kidney because of the increased urea. So lactic acidosis can be one of the causes. If it were necessary to confirm this diagnosis, how would you do it? Number three. So number three, if it's necessary to confirm, but we've already confirmed, right? We could have, since we are saying it can be lactic acidosis, we look at lactate, the concentration of lactate in blood. So that would be something we could do. Which bicarbonate result should be used to calculate the anion gap? So remember the bicarbonate, we said we have got the actual and we have got SBC. So when you are calculating the anion gap, you use the actual value and not the SBC. And then explain what, okay, the SBC, anyone that remembers? Yes. SBC is the standard bicarbonate concentration that is calculated by looking at the pH and not the actual bicarbonate that is in blood. Is that okay? And then number five, explain potassium result. Why is potassium high? Anyone that can help there? So real quick, remember acidosis leads to hydrogen shifting into the cells, displacing potassium from the cells. And that is what causes potassium to go into blood and then it is high. How would the acid base disturbance in this patient be treated? This is metabolic acidosis. How can we treat it? Anyone that would want to help? Remember, the question is saying this patient has also motor vehicle accident and those things. Fractured ribs, multiple fractures, cord sinus periphery. So what you want to look at is first, because this is acidosis, normally in these conditions, people have lost a lot of water, right? So you want to rehydrate, treat the physical injuries that you can see. You can also give bicarbonate therapy, but remember to be very careful in giving bicarbonate therapy. But that's not the major one. You want to do that normally when maybe the condition is acute. But you want to monitor. You should keep on monitoring the bicarbonate, be monitoring the pH, and also monitor the potassium. Because the basic treatment of this problem is first you are looking at rehydration, the ion replacement, and also look at the potassium. You want to, because there's hyperkalemia here, you want also to be able to consider how you are going to be able to replace that. Not replace, but this is hyperkalemia, it's high already, so you are just trying to see on how you are going to be able to reduce it. Okay, so those are the basic treatments which we look at. Primary cause, treat it. Hyperkalemia, treat it. And then also the acidosis, treat it. But be careful, because when you're treating acidosis, you are using a sodium bicarbonate. It can be a problem. So make sure that you watch out on that. Question number 2. A 60-year-old man presented with shortness of breath, which had developed gradually over several years. He had been a heavy smoker since age 20. On examination, he was short of breath at rest and centrally sinused. He had a barrel chest, shaped chest, and a marked expiratory wheeze. X-ray showed hyperinflation and other signs consistent with emphysema. Arterial blood gas pH 7.2, partial pressure of oxygen 8, partial pressure of carbon dioxide 9, and then we have got SBC 36. Comment on and interpret all the biochemical data. So we can comment on the values. pH is 7.2. Is that acidosis or alkalosis? So this is acidosis. So the next thing that we want to tell is if it is metabolic. Yes. So the next thing we want to tell is if it is metabolic or alkalosis. Let's look at carbon dioxide. If it's metabolic or respiratory. Carbon dioxide is 9 and 9 is above the norm. Okay. SBC is 36 and the 36 is also above the normal. Now remember, if you have got high bicarbonate, it means that is alkalosis, but we've said this is acidosis. So meaning that SBC is not the one directing us what to do. It's actually carbon dioxide. So therefore, this is respiratory acidosis. Because the SBC is high, it means that there's actually compensation. When you look at the partial pressure of oxygen, it's 8. That's actually low. And so that's hypoxia. Hypoxia. So interpreting the biochemical data, there is respiratory acidosis with partial metabolic compensation and hypoxia. Explain the likely cause for the acid-base disturbance. Anyone that can help? Actually, the data has been explained well in the question. Heavy smoker. If you can also be relating smoking, smoking, smoking. Remember the chronic obstructive pulmonary diseases? We actually also will discuss them again in pathology. These guys will be blocking. Smoking actually is going to be one factor that is very, very vital in the development of emphysema. So that is the problem. Explain the likely cause of this acid-base disturbance. You can't remove carbon dioxide from the body. Why? There is emphysema, which is a chronic obstructive pulmonary disease. And so there is failure to remove the carbon dioxide. And then the other problem, you can also confirming he has been a heavy smoker since age 20. So this is a chronic condition. That's where there is even compensation because it's a chronic condition. Number three, if he were given oxygen to breathe by face mask, what would happen to these parameters? Someone wants to explain that? What would happen to these parameters if he was given oxygen to breathe by face mask? Remember, he has got hypoxia, but it is chronic, it is not acute. It's recommended to give high oxygen in acute, but not in chronic. Anyone wants to say something? Yes, it's going to worsen the condition. So when you give high oxygen, the partial pressure of oxygen is going to end up increasing. And that is going to switch off the respiratory drive. That's what is making this patient to breathe, right? So when you switch off the respiratory drive, because hypoxia in this case is the stimulus for breathing, it is going to reduce the ventilatory drive and the ventilatory rate. And so it's going to cause this patient to fail to start removing carbon dioxide from the body. Okay. And that is going to lead to more accumulation of carbon dioxide. When more accumulation of carbon dioxide happens, it worsens the respiratory acidosis. Number four, if he were intubated and ventilated so that his partial pressure of carbon dioxide was rapidly decreased to normal, what would happen to his pH? If you were intubated and ventilated so that the partial pressure of carbon dioxide was rapidly decreased to normal, it's high, it was decreased to normal, what would happen to his pH? So what happens, the rapid correction of the partial pressure of carbon dioxide to normal is going to be a problem because remember SBC is high here, right? So if you reduce the partial pressure of carbon dioxide to normal and the SBS is still high, which is a bicarbonate is still high, it's going to cause metabolic alkalosis. It changes into metabolic alkalosis because here what has happened? Partial pressure has been decreased, okay, of carbon dioxide. So it's no longer the acidosis. It's going to go into the alkalosis because the bicarbonate is still high. So that's a problem. How do these biochemical results differ from those patients with an acute asthma attack? Remember, it's acute. And in acute, the thing is that there's no compensation. So acute condition, there's no metabolic compensation at the same level of partial pressure of carbon dioxide. So the pH that we can see here of 7.2, we expect it to be a much lower. It should be a bit more acidic because there's no compensation that is happening. Question 3. A 67-year-old man with a history of liver cirrhosis was admitted following an episode of gastrointestinal bleeding. He was ill, short of breath, and severely hypotensive. You can see sodium is 139, potassium is 4.8, chloride is 98, bicarbonate is 7, pH is 7.13, partial pressure of carbon dioxide is 2.9. Calculate the anion gap and state if it's high or low. So we can start from there. What's the formula for anion gap? Anyone to give us? So, yes, please. Thank you. So you add the positive ions, you add the negative ions, and then you remove the negative from the positive. So sodium is 139, potassium is 4.8, You are removing chloride, that's 98, plus bicarbonate, which is 7. So this is going to give us 38.8. And this is high. You can as well just use sodium without including potassium. It is still okay. That's actually what was used in the lecture notes. Comment, so calculate the ion gap and comments on if it's high or normal. So this is high. Comment on and interpret all the biochemical data. So looking at the pH is 7.13. That's meaning is acidosis. And then we need to tell what type. Is it respiratory or metabolic? So what is the cause? We look at bicarbonate. Bicarbonate is 7. That is low bicarbonate. So we have lost bicarbonate, right? So this is meaning this is actually metabolic. Because if we looked at carbon dioxide 2.9, this is low. Remember the normal is like 4 to 6. So this is low. So this low carbon dioxide is meaning that there's actually a respiratory composition. So this is metabolic acidosis with partial respiratory composition. Explain the likely cause for this acid-base disturbance. Metabolic acidosis, again, the likely cause lactic acidosis, diabetic ketoacidosis. Especially look at this. This patient has got liver cirrhosis. So there's a problem with the liver and episodes of gastrointestinal bleeding. So if this patient is bleeding, what do we think is going to be happening? So when you look at the liver, it can either be lactic acidosis on that basis. The GIT bleeding can as well be a cause. Okay, because remember acidosis, we are going to be losing bicarbonate. Actually, in the bleeding, we'll be losing this base. Unless vomiting, that's the one that would have caused the alkalosis. How would you treat this patient? Treating someone with metabolic acidosis. Remember the treatment is still the same. You want to correct first the underlying cause, you want to replace, rehydrate, and then you want to look at the ions. So this is metabolic acidosis. You can actually resuscitate with normal saline, and also you can give blood transfusion. Why blood transfusion? Because there's bleeding here. Remember, you are treating the problem, and then treat the other underlying conditions like the liver cirrhosis and the hemorrhages in the GIT. So that's what you want to do. The normal saline, remember saline is sodium chloride. When you put sodium in the body, water will be following, so that is going to also help in rehydration. At the same time, the chloride, this guy chloride is basic, and this is alkalosis. I mean acidosis. So you are trying to introduce something that is a bit basic, right? Number 4, an 18-year-old woman was admitted to hospital repeatedly over a period of 6 weeks with a history of nausea, weight loss, weakness, and fainting. Each episode had similar biochemical finding and responded to potassium supplement. Then why you can respond to potassium supplement is if you have got hypokalemia. Sodium is 140, potassium is 2.4, chloride is 87, urea is 7, and then creatinine is 50, bicarbonate is 39, pH is 7.5, partial pressure of carbon dioxide is 6.4. Is this acidosis or alkalosis? So this is alkalosis. Huh? Thank you. Alkalosis because of the high pH. So now we need to look at if it is respiratory or metabolic. Looking at if since this is alkalosis, Alkalosis is either there is an increase or gain in bicarbonate, or there is a decrease in carbon dioxide. So if it decrease in carbon dioxide, that will be respiratory. So look at bicarbonate. Bicarbonate is high. That means that this is metabolic because 39 is higher than 24. And then carbon dioxide is 6.4. It is slightly high. So meaning that this is a compensation. There is a respiratory compensation that is happening since this is a metabolic problem. So we have got metabolic alkalosis with partial respiratory compensation. Besides that, because of responding to potassium supplement, actually even looking at the value, potassium is low, so there is severe hypokalemia, and then you can also see urea is low, and that is also uh, okay. There's also a problem with urea, and what else can we look at? I think these are the things, and also creatinine. Now, normally they're supposed to give normal standard values for each one of these in the brackets. For the urea is actually increased, so high urea and creatinine is low. Supposed to give the normal values in the brackets there, but those we can just search for them for now since they've not been given, which they're supposed to give. If they've not given, for me, I wouldn't trouble. I've seen some where they've not given, but for those, then they're trying to ask you for these which are common, like the pH. This is common, partial pressure of carbon dioxide and bicarbonate. At least these ones, we can be able to comment on them even if they've not given the normal value. And then about these others, really not. So the major thing they want us to comment is on the acid-base disturbance. What do the biochemical features suggest? What do the biochemical features suggest which are here? So just looking at the values that we have, if you look at chloride, 87, again, if you compare with the normal value, this is low. So low chloride, remember we said that every time you see low chloride, it's going to be associated with vomiting is the cause for the problem. So this is metabolic alkalosis caused by vomiting because of the low bicarbonate, the low chloride. So that's one thing that we can look at there. And then urea also, urea has been increased, and that means that there is poor renal perfusion. Blood isn't going properly to the kidney where the urea is supposed to be removed. So poor renal perfusion. And if there's poor renal perfusion, that suggests there is also dehydration. Low creatinine. Creatinine is produced from the muscles when they are broken down. So low creatinine indicates a small muscle bulk, because if the muscles are big, they're going to be broken down, and then you're going to have a lot of creatinine being produced normal in, and then that is going to go to the kidney for excretion. What would analysis of the patient's urine reveal? We have said this is metabolic alkalosis caused by vomiting. And we just said that when vomiting is a cause, when you look at urine, there's going to be low chloride in urine. That's what we had mentioned to say it's a diagnostic feature. Low chloride in urine, less than 5 millimole per liter. That is telling us the problem is vomiting. Explain the likely cause for this biochemical picture. As we have said already, vomiting would be the cause. A 60-year-old man complains of a 4-week history of increasing weakness as well as mild polyuria and polydipsia. On examination, weakness of the limbs was confirmed. It was normotensive and adequately hydrated. Sodium is 137, potassium is 1.7, chloride is 120, bicarbonate is 8, urea is 7, comment pH is 7.2, carbon dioxide is 2.8, SBC is 9.5. Comment and interpret all the biochemical data. So looking at pH, this is low pH, this is acidosis. So we look at acidosis can either be increase in hydrogen or decrease in base. So if we have got a decrease in bicarbonate also, or we can have an increase in carbon dioxide if it is respiratory. So carbon dioxide is not high, so meaning this is not respiratory. And then look at bicarbonate. Where is it? Bicarbonate is 8, which is low. That is metabolic. So this is metabolic acidosis. Because carbon dioxide is low, that is a composition, partial composition that is happening. Look at potassium. Potassium is very, very low here. So this is the severe hypokalemia. What else can we look at? You can also look at urea being very low. Urea being low is going to be suggesting renal impairment. Is the combination of hypokalemia with acidosis unusual? In which condition can this occur? Anyone that can answer for this one? Anyone? So, is the combination of hypokalemia with acidosis unusual? Yes, it is unusual, isn't it? In which conditions can this occur? Normally, alkalosis, normally what? This hypokalemia supposed to happen with alkalosis. But for us, if it is acidosis, then we are thinking renal tubular acidosis. Number 3, explain the likely cause of this biochemical picture. So we have said this is metabolic acidosis, but we have got hypokalemia. So meaning that this is renal tubular acidosis. What other investigations might be helpful? So this is the blood picture. You can also look at urine pH. So for the urine pH, if urine pH can drop below 5.5, then it's going to be, so when you get acid, you start loading in the body. If the pH drops very much, then you're going to be thinking the problem is in the proximal tubule. And then you can also looking at bicarbonate. When you look at bicarbonate, phosphates, glucose, amino acids, these are substances which are going to be increased. Remember we said if it is renal tubular acidosis, one cause can be Fanconi anemia. Fanconi anemia is not only acidosis that you're going to see, you're also going to see increase in phosphate, glucose, amino acids. So if those things are high, it is going to tell us that this is a renal tubular acidosis from the proximal tubule, or type 2 renal tubular acidosis. Question 6. I've got a few more questions. A young man was involved in a road traffic accident. And sustained severe chest injuries. He was struggling to breathe and in great distress, but fully conscious. You can see the pH is 7.24. Carbon dioxide is low. So pH being low, this is acidosis. Carbon dioxide is 8. This is high. This is respiratory, isn't it? Because SBS bicarbonate is also high, so this is the respiratory composition. I mean metabolic composition. So this is respiratory acidosis with actually SBC is 25. The normal is like from that's 20 to somewhere 30, isn't it? If we check on the normal values. So there's no compensation. 25 is normal. There's no compensation because the normal is in this range. And then look at oxygen. Oxygen is 8. That's low also. That's hypoxia. Work out the possible causes for this acid-base disturbance. So what is the cause of respiratory acidosis? Remember we said that the bigger problem when it comes to respiratory acidosis is any condition that could be causing difficulty in breathing out. And we've been told this one was involved in a road traffic accident and sustained chest injuries. So what could cause that would be the actual crash injury to the chest, multiple rib fracture, and maybe the lungs had collapsed so you can't breathe out. A young woman is admitted to the hospital unconscious following a fall. Her respiratory rate is persistently rapid. It's rapid. That's why you can even see the partial pressure of carbon dioxide is low. She's removing a lot of carbon dioxide. So pH is 7.4, that is alkalosis. And this alkalosis, you look at carbon dioxide, the cause can either be you have got low carbon dioxide or you have got high bicarbonate. Bicarbonate here is not too high, but look at carbon dioxide, it's low. So this is also respiratory. So respiratory alkalosis, and then the bicarbonate is also low, so there is compensation from the metabolic part. The pH isn't even that very high. Look at this, the normal is 7.35 to 7.45. So you can see this is nearly full compensation. So we'll say there is respiratory alkalosis with almost complete metabolic compensation. Oxygen is 12, this is normal. So there is no hypoxia. Work out the possible cause. What are the possible causes of respiratory alkalosis? And we said respiratory alkalosis, the problem is anything that is making you to breathe very, very fast, right? Anything. So hyperstimulation may be because of the brainstem injury, but it can also be ingestion of, let's say, the salicylates. I can just say aspirin, that term I'm mentioning. Remember, those were stimulating the respiratory system. Second from last question, actually there are two more. A young man had been complaining of his to his general practitioner of tiredness and weight loss. On questioning, he admitted to excessive thirst, passing more urine than normal. He was scheduled for, and these are actually symptoms of diabetes. He was scheduled for assessment in hospital the following day, but by then he was feeling drowsy and unwell and vomiting. On admission, was found to have a blood pressure of 95 stroke 60 with a pulse rate of 120. Cold extremities, breathing was deep and seething. Sodium 130, potassium 5.8, chloride 105, urea 18, creatinine 140, glucose 32, bicarbonate 3 to 5, pH 7, partial pressure of carbon dioxide 22. Comment on the results. So starting with the pH 7.05, what is that telling us? A pH of 7.05, that is telling us this is acidosis. And acidosis again, we can either have high carbon dioxide or we can have low bicarbonate. So looking at bicarbonate is 5, that is low. Carbon dioxide is, this is actually supposed to be a 2 because this 2 is part of the formula, so that is low. So this is metabolic actually. So some other things we can mention, because there are a lot of ions being mentioned here. Sodium is high. Sorry, sodium 130 is very low. The numbers are like somewhere 145. So this is hyponatremia. Potassium is high, 5.4. The number is somewhere 4.8. So that's hyperkalemia. Urea has been increased 18. Creatinine 140 is also high. Glucose, this is 32. It's high, hyperglycemia. And then we have got metabolic acidosis with partial respiratory compensation, because you can see the pH is 7.05. That is not too near to the normal. So there's just partial compensation because of the low carbon dioxide. Work out the possible cause. What are the possible causes of metabolic acidosis? So here you can see from the excessive thirst, that's telling us diabetes. So this is diabetic ketoacidosis. A young woman is admitted to the hospital 8 hours after taking an aspirin overdose. You can see the pH 7.48, that's alkalosis. And then you look at the other things. If carbon dioxide is high, this means it's respiratory. If bicarbonate is the one that is high, this is going to be metabolic. Carbon dioxide is 2, that is very low, isn't it? Oh, for this is alkalosis. Carbon dioxide is supposed to be low. It's not acidosis. So low carbon dioxide, so meaning that this is actually respiratory acidosis. And then this is supposed to be bicarbonate this side, and the bicarbonate is 11, that is low. So there is some form of compensation which is happening. So we comment on the result is respiratory alkalosis. That is the problem there. The presence of low bicarbonate at first suggests almost complete metabolic. Look at the pH 7.48. It's nearly to the normal. So this suggests almost complete metabolic compensation. Okay. But then the thing is that this patient took aspirin. Metabolic compensation takes time. So there is no way there was metabolic compensation because it takes time. So instead, this kind, we can call it a mixed acid-base disturbance, because where you have got bicarbonate being low is telling you acidosis. And then where you have got the pH being like this is telling you alkalosis. If this was a chronic condition, we would have said yes, there's compensation, but this is aspirin overdose. There is no way there's going to be that compensation. So this is going to be a mixed acid-base disturbance. Work out the possible cause. The possible cause is the same poisoning by the salicylate, the aspirin. Okay, so that is that. And that guy who actually stimulated the respiratory center, but later the same salicylate or the aspirin is going to cause metabolic acidosis at the same time. Number 10, last question. 15-year-old boy is admitted in a comatose state. His mother stated that he had complained of excessive thirst from about a week previously. She thought he had lost weight over the past few days. On the day of examination, he had vomited repeatedly and had become drowsy. On examination, the patient was comatose, deep and rapid breathing, osmo breathing. Breath smelled acetone. Signs of dehydration were present. Loss of skin turgor, dry mouth, sunken eyes, pulse 110, BP 90 out of 50. Deep stick test of urine showed glucose 3 positive, ketone 4 positive, pH 5. pH of 5, 4.8, 4.35 to 4.45. You can see this is like a very high pH. But now the problem is that for this question, it's actually not part of this topic. We'll discuss it when we talk about diabetes. What type of acid-base disturbance is present here? This is actually known as a hyperglycemic hyperosmolar coma or honk, non-ketotic. Calculate the anion gap. The an Okay, here first we want to state the acid-base disturbance, not really what I'm stating now. So the acid-base disturbance, let's look at pH is 5. That is high, isn't it? So we have got a high pH. And then what else? Let's look at the causes of high pH. This is already alkalosis. Okay, which one are we using? Oh, so there is this value and then there's this value. Okay, so we can use this one which is downer. So this one it was for the urine, not the blood. Yes, thank you so much. So use the blood pH 7.05. So the normal is supposed to be 7.35, isn't it, to 7.45? So this is low, this is acidosis. And then what would be the cause? If carbon dioxide is high, that would be respiratory, but carbon dioxide is low here. Bicarbonate is 5, that is also low there, isn't it? So that means that this is metabolic acidosis. Calculate the anion gap. We are going to get the 130. I'm not going to add potassium. I'll just remove chloride, which is 100. Then plus bicarbonate, which is 5. This is going to give us like a 25. So anion gap is 25, and that is high. So what is or are likely reasons for the elevated urea and creatinine? Anyone that can comment on that? Why elevation in urea and why high creatinine? Anyone? Yes. So creatinine, high muscle bulk, and then how about the other one? hmm Okay, let's comment on the other one, and then we talk about the muscle bulk and muscle wasting, and then the other one. So we are saying what is or are likely reasons for elevated urea and creatinine. So urea, when it is high, pardon, would you say that again? Okay. So urea, it can be cause of the some problems with the kidney, because that's where there is this excretion happening. So one thing is when you are making glucose in gluconeogenesis, you can be making urea, and also maybe there is a problem with the before the kidney, so pre-renal failure that can cause that increase in urea. When you look at creatinine, creatinine is like supposed to be fully uh, it's supposed to fully pass on the glomerular filtrate. So if it's high, it means that there's a problem on the glomerular filtration. So there's a reduction in the glomerular filtration rate, or there's a problem, there's an artifact there. One thing could be because the person has got a lot of muscle, because if it is low, it means that there is low muscle that is leading to, if there's a breakdown, you can only produce lead to creatinine. But in this case, we can talk about the kidney, there is a problem with the kidney. Number four, what treatment is appropriate? So remember the treatment is all the same, but because this person has got diabetics, can talk about infusion of insulin. And since this is diabetic ketoacidosis, is it associated with type 1 or type 2 diabetes? Anyone? Remember there is we can see this thing like the acetone. Okay, this patient was gaining weight later on, but we can look at some other things because type 2, we're supposed to have honk as a result. Type 1, there's going to be diabetic ketoacidosis. You can see the acetone, the ketone bodies being produced. So this would be the main thing that will help us to determine. So we can also infuse insulin. Insulin is the only treatment for type 1 diabetes. And then, so we are saying the treatment options, we can use insulin. Besides the insulin, we can as well look at infusing isotonic sodium chloride. Also looking at the replacement of potassium, because if you look at potassium, 5.8, this is actually slightly high. So what you want to do is to correct this mistake in potassium being high. So potassium correction. Which biochemical parameter should be frequently monitored? We did mention this already. So you can monitor the acid base, the glucose, the sodium, the potassium, and the urea and creatinine. What? Why is potassium slightly increased? Do you think it may change during treatment, and why? Potassium is slightly increased because it's moving from the cells, right? It's moving from the cells. So during treatment, it is going to increase again. Why? Because it's going to be taken. It's actually going to decrease because it's going to be taken into the cells. Okay. So do you think it may change? Yes, it's going to change. It's going to decrease because it's going to be going back into the cells. And actually, the way we are treating that is there's potassium replacement, where we're putting potassium that is going to be pushing the potassium into the cell. Not really replacement as putting it replacement since it's already high. So helping in being able to push the potassium back into the cell, and then that is going to restore the normal concentration. Why is sodium low? Does it necessarily imply sodium depression? So for this one, remember when the sodium is moving, it doesn't really imply sodium depression, no? Yeah. So what is happening is when potassium is moving, when potassium is going into blood, sodium is going to be moving from the urine back. These guys are supposed to be exchanging, right? So why is a sodium low? Okay, this is also low because it's still supposed to be going into blood and not vice versa. It's still supposed to be increasing. So ECF, the extracellular fluid, is going to be expanding. Remember, this patient has got glucose, right? Because normally potassium is going into the cell, so it's supposed to have a high potassium. But because of the sugar is going to cause that water to be going in the direction where the sugar is, that is in blood. Because of that, there's going to be more like dilution, and so the sodium is going to be low. So hope that's okay. Because of the expansion of the extracellular fluid by osmosis because of the effect of glucose. The bicarbonate is low. Should it be corrected with sodium bicarbonate reaction? So there, it shouldn't be. You shouldn't correct it because when you give the sodium bicarbonate, it will actually get to regenerate with ketone anion metabolism. It's going to regenerate, so it's not really useful. What type of diabetes is likely here? We said this is diabetic ketoacidosis. And for diabetic ketoacidosis, it's a complication of type 1 diabetes. So that's type 1. So basically, that is it with this paper.